I'm pleased to welcome you to our second Wednesday of the month CME event, tonight featuring presentations based on the winner in the case report category of the 2025 second annual poster competition among trainees. While it can be challenging to match and personalize the right interventions to every patient, the task is that much more daunting when the clinical presentation is so complicated and atypical that it's hard to establish a diagnosis, let alone formulate a treatment plan. We will dive into just such a difficult but exciting scenario in a minute after brief housekeeping. Once this evening's formal presentations have concluded, you can raise your virtual hand and ask questions verbally. If you prefer, you can enter questions in writing into the chat at any time. We'll get to questions at the end of the presentations. In the coming days, watch out for an email from Ms. Kathy Thompson, our CME director, with details on how to claim your CME credit for this evening's session, as well as a handout provided by our presenters. And looking ahead, we are planning a third annual trainee poster competition in association with next spring's Presidential Symposium and Gala. So please keep an eye on the WPS website as well as your inbox for details in the coming weeks. Now, it is my pleasure and honor to welcome Humaira Siddiqui, CME Committee Rockstar, and our WPS President-elect, who will introduce tonight's award-winning presenters. Take it away, Humaira.
Thank you. Thank you, Dr. Rudorfer. It's a pleasure to be here tonight, especially having the opportunity to introduce two highly esteemed clinicians. One was a former attending of mine, and so I'm especially thrilled to introduce both of them. So I'm first going to introduce very intelligent clinician, Dr. Jing-Xiong Pu, MD. Is a third-year psychiatry resident at St. Elizabeth's Hospital in Washington, D.C. She's an international medical graduate with a particular interest in complex diagnostic work, psychodynamic thinking, and the role of cultural identity in shaping how patients and clinicians make meaning of illness. During residency, Dr. Pu has contributed to multiple academic projects and has presented her work at the American Psychiatric Association annual meeting and multiple regional conferences on topics such as anorexia nervosa, subtherapeutic antipsychotic dosing, and trauma-focused therapy modalities. Dr. Pu co-leads her residency's Balance Group, where case presentations are used to understand the role of clinician-patient relationship to optimize clinical care, and serves on the Council of the American Balance Society. The next person I'm going to introduce is often called in to help disentangle complicated clinical presentations. So our second speaker this evening is Dr. John W. Stiller, who is a board-certified neurologist and director of the Neurology Consultation Service at St. Elizabeth's Hospital. He completed his neurology residency at Mount Sinai Hospital in New York and was elected a fellow of the American Academy of Neurology. Dr. Stiller brings in extensive clinical experience. Within the past 2 decades, he's been focused on behavioral neurology, neuropsychiatry, and chronic traumatic brain injury. He previously served as chief physician and neurologist for the Maryland State Athletic Commission and is currently a member of the Mood and Anxiety Program research team affiliated with the University of Maryland. Dr. Stiller is also a contributing member of the Physicians for a Healthy Democracy and remains deeply engaged in medical education and public health advocacy. So this evening's presentation is entitled More Than Just a Mind Lost, a Case of Ex-ALD Hiding in Plain Sight. Take it away.
Good evening, everyone. My name is Jing-Xiong Pu. I'm a psychiatry resident at St. Elizabeth's Hospital, and today I'll be sharing a case that has stayed with me, not only for its diagnostic complexity, but for what it taught me about being a psychiatrist. Please give me 1 second to share my screen. Okay, so our objectives today are threefold. So first, I want to help everybody recognize how a rare neurodegenerative disorder can masquerade as psychiatric illness. and also how to catch it before it's too late. Secondly, we are going to explore why this diagnosis was missed and what it says about the limits of our clinical lenses. And third, I want to invite everybody to explore when we are diagnosing patients, think about not just what is the diagnosis, but also what if we are wrong and actually patient knows something that we don't know. So I will take the case away. This was the patient's actual quote on arrival. Incontinence or something, I don't know. I'm here, aren't I? They say I have schizophrenia, but that's BS. I'm just highly intelligent. I want to invite everybody to think about, what does this chief complaint resonate in you? Obviously, there's grandiosity, and maybe the patient also has poor insight. But let's move on to the case. Patient is a 34-year-old single, undomiciled heterosexual Caucasian male. He presented to St. Elizabeth's Hospital as a transfer from an outside hospital for further stabilization of psychiatric symptoms. He was FD12 to the outside hospital 1 month ago by his ACT team. And per FD12, he presented with racing thoughts, irritability, paranoia, auditory hallucinations, and disorganized thought and behavior. He was initially non-compliant with medications, but in the end agreed to a long-acting injectable. So he was receiving a long-acting injectable, namely Risperdal Consta, at this outside hospital. When he arrived at St. Elizabeth's, he insisted that homelessness was his only problem. He also spoke about publishing several books and said he didn't need medications, explained that people were jealous of his intelligence. Right now, it still kind of sounds like textbook grandiosity, but I just want to plant a little seed in here. What if his logic had just one kernel of truth? And what if the delusion was protecting a truth we haven't yet uncovered? He denied depression. He was eating and sleeping well. No anxiety, no suicidality, no visual hallucinations. And no suicidal ideations, and also no homicidal ideations. His chart was stacked with diagnosis, and over the years, he was labeled with schizophrenia, mood disorder not otherwise specified, bipolar, malingering, cannabis-induced psychotic disorder, schizoaffective disorder, you name it. He has been treated with multiple antipsychotics, long-acting injectables, and antidepressants with little to no consistent improvement. So look at the medication trial. Isn't it so tempting to view it as a treatment-resistant case? And also, I want to just remind everybody what kind of place St. Elizabeth's is. It's the most tertiary place in the area, which means we take a lot of patients who are more severely mentally ill. We take a lot of the treatment-resistant cases. We also take a lot of forensic cases. So, well, isn't it just so easy to think he is a treatment-resistant case? He had several past hospitalizations, 2 in Virginia, and 3 CPAP admissions, 2 inpatient admissions in DC. He had 3 FD12s, counting this FD12 that led him to be admitted to St. Elizabeth's Hospital, and his longest inpatient stay was 1 month and a half. He was in CBT for several years. He had no suicide attempts, but he has expressed SI in the past year twice, and both times he was FD12'd. He never had any homicidal behavior, but he has accidentally caused fires. His past FD12s highlighted actually a lot of things that we saw on this FD12. Racially provocative, has a lot of grandiose delusions, such as being summoned by God, has a lot of disorganized or inappropriate behavior, exposing himself to children and adults, hearing God's voice, being related to celebrities, and non-compliant with medications and not taking care of his ADLs. In terms of substance use history, that is a whole another story. So he had a significant history of substance use, alcohol for 13 years, mainly to help him sleep. First use was 18 years old, and last use was 1 year ago. He's had history of DUIs, but we don't know about blackouts and withdrawal seizures. He's also had a pretty significant history of cannabis and K2 use. He's had 10 ER visits due to K2 use and history of passing out on sidewalks. He's been using cocaine daily since 18 years old. And he's also a chronic smoker of cigarettes. Per records, he has also used methamphetamine, ketamine, and ecstasy since his early 20s. However, by the time he reached St. Elizabeth's, he was clean for like a month because he was also admitted at an outpatient outside hospital. So he has been clean for a month. In terms of past medical history, he has never seen a PCP or dentist as a child or an adult. His past medical history was actually pretty significant for urinary and fecal incontinence started 1 year ago. Also, 1 year ago, he had memory impairment. He's had some possible head injuries. He's had a history of chickenpox, TB was negative, and no history of any other relevant illness. At the outside hospital, it was documented that he had a normal motor sensory exam. However, there was no full neurological exam. His admission labs and vitals throughout the stay was also within normal limits, and there was no head imaging available. At St. E's, his vitals was within normal limits. Admission labs was significant for elevated total cholesterol and LDL. In terms of neurological exam, he deferred sensory reflexes and strength. However, while we observed him walk, we saw he had an unsteady gait. He had no allergies to drugs or medications. His family history is significant of late onset multiple sclerosis in his maternal grandmother and depression and alcohol use in maternal uncle, nothing else otherwise. In terms of social history, he was born in Virginia. He was an only child, no pregnancy complications. He had no history of trauma, abuse, or neglect in childhood. He had a bad relationship with parents. He actually was functioning pretty well premorbidly. He had an above average school performance. He studied computer science. He was employed at VCU for 1 year and earning money also with benefits. He's worked for like around 10 years in various jobs, mostly involving computer programming. He moved to DC to stay with a friend and eventually was estranged from family. He was sexually active with multiple partners with inconsistent protection use. He became homeless around 1 year ago and had some history of bullying and physical assault while he was staying in shelters. He ended up receiving SSDI monthly. In terms of legal history, he had several charges, including trespassing, felony, unlawful entry, petty theft. We also had a chance to collect some collateral information. Per his colleague, he was a brilliant person. Per his clients, he had trouble completing his work. And per his mother, his house was very messy and worse than the dump. So now moving on to mental status examination. His physical appearance was, there are a few things that really stood out. He had spiked blonde hair with sticky white substances on top, and he was observed to have urinary incontinence during the exam. In terms of psychomotor activity, he was tense, and also he had this intermittent circular motion of his head. And per himself, he could partially suppress it, and he says the movements make him calm down a little bit. He was uncooperative, he was guarded, he was tangential, he had grandiose ideation and paranoid persecutory ideation on examination. He is alert and oriented in all spheres, and although his short-term memory was impaired, his fund of knowledge is pretty good, and we could see that his baseline was actually pretty good, at least of average intelligence. But he's very impulsive, and insight and judgment were both poor. So moving to now, our initial diagnosis was because he had both mood symptoms and also psychotic symptoms, although we were not very sure what happened first, what happened later. We put schizoaffective disorder unspecified as a working diagnosis. There's also polysubstance use disorder and hypercholesterolemia. However, there are a few things that doesn't add up. All those working diagnoses cannot explain why he would have urinary and fecal incontinence, why he would have gait instability, why he would have the neck movements and memory loss at such a young age. And also, we were very perplexed about why nobody did a full neurologic exam at the outside hospital, and nobody ordered any head imaging for him. Is it possible that it has always been something else causing this presentation, while all this time, all his clinicians are managing him as a psychiatric case? So this is time when we contacted Dr. Stiller for a neurology consult. We also held his risperidone consta and started Seroquel as an antipsychotic because we were also not sure if the neck movement was an extrapyramidal symptom. So we want to use something that has less potential to cause EPS. And I think now is a good time to pass over the mic to Dr. Stiller.
So I have control of this now, or?
I have control of this.
Okay. So when we were asked to see him, originally I thought that this was a patient who was diagnosed with schizophrenia, not responsive well to treatment, long history of polysubstance abuse, multiple psychiatric hospitals, and that now he developed an interest in movement disorder, which, by the way, is a really common presentation at St. E's. And probably more often than not, that description would be right. So next slide. Is that okay? Good. But it didn't take long to know this was much more complicated because when I walked in, he was urinating in his pants, and he had no idea he was doing it. So that was the first clue, and then the mental status was just as Dr. Pu said. So cognitively, he had trouble. Behaviorally, he had troubles. And on exam, so he had some mild anisocori, he had some impaired extraocular movements, the myosin sign, when you tap there, which could have either been from extrapyramidal or diffuse brain dysfunction. Okay, but he had bilateral, all limbs were spastic. Okay, with hyperreflexia, a cortical-spinal pyramidal tract, that is, upgoing toes, and when I mean basically, you can have subtle findings if you're talking about limb ataxia. So people do like finger to nose, like something like that. And by the way, a clinical prolonged exam, if you have somebody you think is ataxic in their arms, don't do finger to nose because you're going to end up poking them in the eye. So then do finger to tip of the chin instead. So he had it this involving all of his limbs. It was also involving the midline. He was, walking more like a drunk. Okay. And he had some bradykinesia. It mainly was the type of one where when you ask patient, to do this quickly, and if you don't ask them right, everybody cheats. They start going like that. But if you explain it correctly and they keep the amplitude, they'll be slow. And if they don't, they'll do this. Uh, and with him, the question came, is this part of an illness or is it part of the treatment? And then he did have these slow neck movements, which when you ask him why, he said it makes him feel better. Okay, well, can you stop it? And he could, but not for that long, and then it'd be like a rebound. So whether or not phenomenologically would be described as a tic, it was tic-like. And the question with that was, is that due to drugs? Is that due to his illness, whatever it is? And he also had some mild distal vibration. So there are a lot of abnormalities, and they weren't subtle. Okay. And I know when people say, well, you're a neurologist, and it reminds me of my physics professor who would say, it's obvious that. And then I had to say, well, maybe obvious to you. Okay. But in fact, this wasn't subtle. Okay. So I can go to next slide. Okay, next slide. Okay. So first I'll talk about the head and neck movements because that's what we saw. They were partially, they looked like it, they acted like a tic. So the question is it due to the medicine? Could it be tardive tic, which people have described? Uh, or is it more the stereotype they talk about that are associated with an illness itself? Well, the time wise was pretty short for being tardive, although you'll find papers that say it can be short. Uh, and the so and the so I think that I was leaning that this is probably part of the illness. And it also is possible that when your brain's perturbed and not working right, the general rules of how long it takes before you develop a tardive may not apply. So it could be some interaction between those two things. And as an aside, as long as I'm not going to take too long, some excellent, I'm good friends with Joe Klein, if you know him, and Danny Weinberger. And years ago, I found this when I was looking about this. Joe Klein and wrote a paper on movement disorders and these inherited metabolic disorders. And I asked him, because I didn't see anything in it, and what do you think? Well, he said probably a disease, or ask somebody else. So the next one, I guess to say a key point though is that always consider an illness, not just the treatment, although a lot of times the treatment is involved. So we had to have a differential diagnosis for progressive multi-system disorder because that's what this was. It was basically a kind of diffuse findings with multiple systems involved, and it didn't look like, or the limited history we had, it didn't look like a focal, a multifocal, a stepwise presentation, acute, subacute. So it was most likely a diffuse disorder of the brain with multiple systems being involved. Okay, that was probably slowly progressive over time. And also, you could explain all of this stuff through perturbations of white matter, okay, networks. And so, even before we saw the MRI, this is true, I'm not making this up, even before we saw the MRI, we had the X-linked adrenal leukodystrophy, but the leukodystrophies up, high. And then chronic he used so many different types of drugs for so long, which can cause brain damage. That could possibly be it. But another lesson I think here is that almost never is it. The drug in somebody who looks like this probably made everything worse, but would be very difficult to explain it, even if you add there's an underlying psychiatry. So there's a broad differential on this. I'm not going to go through the whole differential of this. I think it's worth when MS is put down, and so that the classic exacerbating remitting MS is not this. But what about primary progressive MS, which is mainly a white matter disease? So that would have been a differential, but even that doesn't look like this because a lot of these other things that you're looking at, like autoimmune vasculopathies, you'll have a clear multifocal findings, and his everything was involved, you know. So even that was high up, you know. But the next step was going to be brain images. You got to ask yourself, how could somebody not do brain imaging on a patient like this? You know, it maybe the answer is that it was done and nobody we saw it or we didn't see it. But if you ask me why, I don't know when psychiatrists decide not to do brain imaging. But number one, no one's going to give you an award for that. Okay, and I mean, his brain wasn't working right. Okay, you know, and if you think that you're certain that you can explain it all by a primary psychiatric illness, good luck. But in my view, you'd have to be born, be there when the patient was born and have that kind of history. So, I know they still give the lectures that, save money. Why are you doing imaging if you don't need it? But that's, you know, anyhow. So when we did the brain MRI, you know, why'd we do it? Because we want to look, is it structural disease? Is there any evidence of inflammatory disease? This is one slice, okay? And you can see, well, you can see what's white. So this is a flare sequence, and all that white stuff. You see it's pretty posterior. You see the corpus callosum, you see parietal occipital pathways, and you see bilateral internal capsule are involved there too. And if you look carefully at the rest of it, there were subtle abnormalities that were evolving other tracks, including because somebody wants to say, well, what about the behavioral and psychiatric? Well, I'd say, well, frontolimbic system is involved also. Okay. So this is, I remember looking at textbook pictures on X-linked adrenal leukodystrophy, and they described it. Our case had better pictures than any of the texts. And if somebody would have, even if you have no idea what you're doing, people used to say, if you have a lousy neurologist, a good radiologist neuroradiologist can make up for that. But if he had had an MRI, it would have been listed in the differential just from the MRI. Okay. So something to think about. Okay. Okay. And since we're thinking about that, the nature of the disease, this is what you order. These very long chain fatty acids. It's adrenal. You look at adrenal function, and then you would get genetic testing. There's a reason to do it, and he tested positive. So that pattern that you're seeing there is what you see in X-linked adrenal leukodystrophy. He did have mild adrenal insufficiency, and then we did do the genetic testing, and he had the classic described ABCD1 gene abnormality, which has to do with making the gene makes a transport protein, a transmembrane protein that gets the very long chain fatty acids into the perioxisome, so it gets metabolized. If you can't get in there, then you run into all this trouble with the myelin. I think next. Okay. So people, this is if there's any people insurance people with pain in the neck who will ask you, well, why do you need that test? And probably, you already know what it is. Why do you have to test the gene? Well, we don't know for sure what it is. There are mimics, okay, but it's also essential for family counseling, carrier detection, trials, and it should be done, and it certainly should be done in academic centers. Okay, the short answer, right? Precision. Okay, so yeah, just interest precision. Okay, so in summary. long psychiatric history, substance history, presented with progressive multi-system disorder involving multiple systems, pyramid, electropyramidal, cerebellum, and/or connections to brainstem, tick-like features, and probably some peripheral neuropathy. The MRI, the very long-chain fatty acids, genetic testing confirmed that this was adult onset X ALD. And so what do we always reconsider the diagnosis when a psychiatric illness is treatment resistant and accompanied by neurological red flags. Uh, and and I work with a lot of good psychiatrists, not some not so good, but good psychiatrists will pick up. You don't have to do a formal neurological exam. You watch the person walk, right? Okay, and how he sits down, and you'll get a sense of that there's something abnormal in the exam, and and picking up those red flags are important. Okay, and okay, so next slide. Okay, so why was it missed? And I don't think it's a miss because we're dealing with idiots. Okay, I think once the anchor, so once everybody's sure what it is, you've seen 6 psychiatrists, 7 psychiatrists, maybe a neurologist, the long history. Oh, okay, we know what this guy has, uh, and then you have to stop and say, wait a second, maybe we should think that something else is going on. And that again is looking at red flags. In this day and age, I don't know how, like in private practice, any type of doctor, can practice with the volume they may ask you to do. Well, let's say 80%, right away it's schizophrenia, or 15% still requires analytical thinking. How do you do that? Well, the only way you can do that, because you're gonna have to spend more time in these complex cases, is picking up on red flags and say, wait a second, this one we have to spend more time on. Okay. And so don't always want to keep an eye on that. And also either delayed or no neuroimaging here. Okay. So, you know, basically, I'll tell you, so when this happened, whatever the hospitals or hospital were that we knew he came from, uh, and I always tell the residents this, let them know, so we have other cases we pick up that's a misstep where let them know it's not to tell them, oh, look, you don't know what you're doing. We know what I'm doing. It's because if I miss something, I want to know, I want to learn from it. And for this and some other cases, they couldn't get them. That's how busy they could not get them. They could not. In other words, so it's likely whoever saw this never learned from it. Okay. Uh, and that to me, so that's very important. So next, good.
Yeah,
I
that
didn't
would
I
be.
didn't take too long, did I? Because when I was president of the medical staff, it's St. E's, I had to have somebody, another member time me, okay, to tell me, otherwise I would have kept going on. So I'm better at that now. So Dr. Pooh, go on.
Thank you so much, Dr. Stiller. So after it was the diagnosis of X-linked adrenoleukodystrophy was confirmed, we revised the diagnosis. So the primary diagnosis would be adult onset cerebral XALD, and his psychiatric presentations will be mood disorder due to non-physiological condition. And there's a bunch of substance use disorder, and also the circular movement. The differential diagnosis will be secondary to XLD or a tardive EPS side effect of antipsychotic or tic or OCE type phenomenon. And we also revised the treatment plan. We mainly targeted the symptoms. We used Seroquel for sleep, olanzapine to control psychosis, escitalopram for depression, benztropine for EPS, nicotine replacement therapy, and also because one of the presentations of XALD is adrenal insufficiency, so we used a lot of hormone replacement therapy, and also other interventions, high calorie diet. He's malnourished, so we help him gain more nutrition, physical therapy, assistance with ADLs, and also we enrolled him in clinical trials for adult onset XALD. So next, I would like to give a little bit of introduction about XALD. Like Dr. Stiller already mentioned, it's an X-linked mutation in ABCD1 genes, and it results in very long chain fatty acids cannot enter the peroxisomes. And the VLCFA accumulation leads to demyelination and adrenal dysfunction. Something very important here is that the genotype does not always correlate with the phenotype, which means even within families, with everybody with the same gene, they might present differently. Or if they have identical mutations, they might have different symptoms. And there are a couple of phenotypes. The most prevalent one is called adrenomyeloneuropathy, and the type that our patient had was adult cerebral ALD, which is the rarest subtype. Although it is an X-linked recessive, heterozygous women are also often affected with myeloneuropathy, but their symptoms often onset later in their life. For very young infants, the hematopoietic stem cell transplantation is the gold standard treatment, but it's effective only in early cerebral disease. Surveilling with MRI is very central in guiding the intervention. And current standard of treatment also include newborn screening and using an MRI-based scoring system, which is called the low score, to determine thresholds for intervention. And also there are gene therapies emerging. So the important clinical message is timing and phenotype matters and surveillance is key. So up to November 2024, 47 states in the United States have initiated XALD newborn screening. And after the screening was initiated, incidence has risen to 1 to 15,000 from 1 to 17,000. And it's only been, a little bit more than a decade. And, newborn screening has become pretty much prevalent in the States. However, when this patient was born, there was no newborn screening. That's also one of the reasons why he waited so long for somebody to diagnose him. Also, something that's interesting to share is in asymptomatic boys with XALD having normal brain MRI, they can use something called Lorenzo's oil. It's a mixture of two fatty acids. It inhibits the production of VLCFAs in the body. There is an Oscar-nominated film made of this topic, and the little boy in this film actually has XALD. However, the evidence of Lorenzo's oil is limited. There's also gene therapy has shown arrest of progressive cerebral demyelination after 14 to 16 months of treatment. That takes us to what lessons can we learn from this case? So most importantly, why was this diagnosis missed? Or it's actually not missed, but why was this diagnosis delayed? So first of all, there was no previous neuro exam, there was no imaging. Like Dr. Stiller mentioned, anchoring, labeling, and inertia exists actually quite prevalently in our day-to-day clinical practice. And also, with the patient's presentation being so severe, the neuro exam could not have been normal at the outside hospital. So maybe that tells us that, somebody skipped neuro exam. And also there is using psychiatric reasons to explain everything. I mentioned at the beginning that it's so easy to label this patient as psychotic, label this patient as treatment resistant, label this patient as drug induced. However, psychiatric reasons cannot always explain everything. And as psychiatrists, we also have to remember that we are still medical doctors. Although many reasons have pressed our role to compress into only the psychiatric aspects, but keeping the medical aspects in mind can really help with our diagnosis. There's also a lot of biases, heuristics, and labels. And this patient actually has pretty atypical presentation, but it was ignored. I also want to bring up Occam's razor, which is the simplest explanation is usually the best explanation. However, it doesn't always apply. Uh, Especially it doesn't apply in people with atypical presentation, immunocompromised patients, or elderly patients. And last but not least, remember what the patient's chief complaint was? It was incontinence. So actually, the patient has been telling us the truth somewhat, and we have overlooked his narrative, sadly. Second, when should a psychiatrist suspect organic causes of psychiatric symptoms? When we see atypical presentation, especially neurologic red flags, and also when they're not responding to psychotropics, of course it can be treatment resistant, but it's always helpful to think about any underlying medical causes, any organic causes. And the next step will be ruling out the organic conditions. Now, some people might ask, what could we have done differently if we had caught this diagnosis earlier? To be totally honest, I am not sure about this answer because, because by the time of this patient, um, screening wasn't that good. And also he has a very rare type of phenotype, which is also like the worst prognosis. There's probably very little that we can do. But what could have changed is maybe we could have raised his quality of life. Maybe he doesn't have to suffer so many psychiatric hospitalizations. Maybe he doesn't have to go through involuntary medication panel. He doesn't have to take so many needles. So the take-home message today will be, don't see the DSM until we have ruled out organic and medical causes of the psychiatric symptoms. And also, it's always very important to take a good history, do a thorough physical examination and imaging. That brings us to, does anybody have any questions or discussion?
That's a fantastic presentation, Dr. Pu, Dr. Stiller. I think it also underscores that as psychiatrists, we are medical doctors, we are physicians, and we have to remember what our roots are. Neurologists and psychiatrists, we're cousins. We both love brains, and not the way zombies do, but but I think it's also underscores the idea of that when we are in a managed care organization setup, whether you're in private practice, it's particularly for private practice, and I have a private practice, I also work in a hospital, and I learned how to order an MRI for my patients. I think it's so relevant because oftentimes we say, well, I'll refer you to a neurologist, and wouldn't it be such a nice thing if you could order an MRI
Yes.
for the patient so that they have the MRI ready when they see the neurologist, that they can really hit the ground running in that consultation. So I'm going to start with the first question because I know folks are going to have some questions. But the first one is, as a psychiatrist, instead of having to refer to my um, uh, neurology for, clinical neurology for psychiatrists textbook, when you're thinking about MRIs, what is the specific order that you might order generic movement disorders in terms of NRIs, without NRIs, MRIs, with or without contrast? And then in terms of, how would you justify it in terms of a diagnosis? And I'm kind of getting into nitty gritty because I used to run utilization management, and I would often tell physicians, help me, help you, help me, help you, help the patient. And so how can you guide a psychiatrist in ordering this lab work, but also putting a diagnostic code so that they can get this done and have that workup, at least reviewed by someone who is either a psychiatrist or a neurologist?
You're asking me that, I guess.
Yes, I am,
Dr.
Dr.
Fu,
Phil.
want to take that? Okay.
Or
So
Dr.
that right, that to a good extent depends on what we're talking about. But so the way, I mean, basically, if you've made a diagnosis, somebody has schizophrenia, somebody says, why do you have to get an MRI? The next thing, well, are you sure it's schizophrenia? Or could this be an organic lesion that looks like schizophrenia? And then you would say, and there are atypical features, and that's why we have to get it. Same thing, you could have migraine headaches, and so, or a headache. Here's a lesson on it. When do you work up a headache? First, or change in headache pattern, worst and cursed, right? Right? Worst headache, you always work it up. Cursed means associated with systemic or medical disorders. First, or it's changed in pattern. Uh, so there's some general rules, but again, uh, a lot of that depends on whether the history is correct. And in this day and age, I do charts, John, a lot of places, and everybody has checklists now. And you have a person seeing you're the same patient, the same time frame, and they're different checklists, right? They're not even checking the same thing. So when your brain's not working right, okay, unless you have a high degree of confidence that we know exactly what this is, we have enough history. I mean, if you've been treating a patient for 10 years with schizophrenia, every time they don't take their medicine, they have a DuPont circle, doing this, you get them back in and put them back in their fine. No, that may not require much of a workup, right? Uh, but it's just it was much easier in the old days when you only had when you had angiograms, spinal taps, EEGs, and some tests that are more like torture, right? Okay, and you basically, it's not worth it. The risk benefit's not worth it. But in this day and age, when it's so easy to image, it's going to be rare that I don't, or when your brain's not working right, that I don't order an MRI, or some type of image if it's an acute traumatic, it'd be a CT. But uh, it's yeah, I mean it may be the patients I'm seeing. I mean, if I like at St. E's, if we looked at all the patients at St. E's, get rid of the pure sociopaths, probably 90% have concomitant neurological disorders. Okay, they have high blood pressure, the microvascular changes, had multiple head traumas, alcohol, drugs, and so when I get a consult, which is the number one consult Chinese that we get, is that in people who have schizophrenia, let's say, what about the cognitive changes? My first would be, well, what are you asking me for? Schizophrenia is part and parcel, has cognitive changes, but what they're really asking, okay, is they're saying, and they're always right, okay, is we don't think we can explain all of these based on the primary psychiatric illness. They're
Exactly.
almost always right, okay?
Exactly.
Yeah,
I'm sorry to
good.
jump in,
Right, yeah,
John,
good.
but you know what? Here's the thing. Um, you, John Stillett, are invaluable to our practices as psychiatrists. And you and I go
Thank you.
back a ways.
Well, yeah,
But
right.
but I'll tell you, it was Ken Rickler who back
Oh, I
in the
remember.
day
Yeah.
said, you know what, Ray? I'm examining a guy and his voices have names. And it was the opening of someone who had a tic-tac charge
Hmm.
driving in DC with a weapon in his trunk. It
Hmm.
was not some multi, whatever kind of charge. And I talked to him, and he was the first ever for me had multiple personality disorder.
Wow. Hmm.
And it was,
Wow.
dissociative, and it was a neurologist, not us as psychiatrists talking about, yeah, he's got voices, he got this, he got that. And he said, Ray, something different about this. And that's what it is. If there's
Hmm.
something different about what we see, we need to call in the troops. And some of the
Right.
troops are like you, man. So
Wow.
here we are, right? And that's how we
Yeah.
make right diagnosis and do the right thing in doing what we are supposed to be, medical
Yeah.
professionals, all of us. So I cannot tell you how much I appreciate this presentation, and I appreciate you being a part of it. And it was wonderfully presented. So I'm gonna
Good to
stop.
see you, by the way, Ray. It has been a while.
Yeah, I'm just some old guy, you know. There you go.
I see some hands up, Dr. Dunlap and then Dr. Cox.
Yes, and I'll just say what I put in the chat, which is a fascinating, Dr. Pooh and Dr. Still, a fascinating case and just an exceptional presentation. So I just wanted to start with that. And talking about things that stand out, when you mentioned that, when you saw him, that he had urinated on himself, and I was thinking, that is not something that we see. Maybe if someone is really inebriated and they're out
Mm,
of it,
yeah,
you might see that. And so even that stands out.
right.
Um, but what I also wanted to say about this case, I just very quickly, I was thinking about misdiagnosis of schizophrenia in Black patients because
Mm,
of bias. And so we see
yes.
that. And so this is different. This is a white guy. And I'm also thinking because of his being disheveled, not caring for himself. And I can see some bias causing people to not lean in as opposed
Mm,
to being
okay.
curious
Right.
about his symptoms. Yeah, so I
Yeah.
really appreciate this presentation. Thank you.
Thank you. I'll add that with him, the drug, his mother was really a nice person, and she had been giving him money, and when that business about the wrecked room, when she saw that and she knew that he had a problem with drugs, then she refused because she thought, she was enabling, to try to get him. But and also, there is bias. We have other cases where when somebody has a lawyer, there's really interesting cases. Nobody believes anything they say, right? Okay. Yeah. I mean, I think you probably remember that, Dr. Siddiqui, that you know, uh, some that PhD from Greece who when by the time I got, she was 14 years. She was originally she fell, hit her head, had post concussion. Then everybody was sure that he was faking because she had a lawyer and was suing. Okay, he ended up having and so yeah, those are all good points. I also want to you know I try to teach psychiatry, and I'm lucky that I work with some really good ones. That, for instance, if you know a patient and they have developed delirium, and you'll know it if it's your patient, you'll know this is not what we see when he doesn't take his medicine. There's something wrong, and then if you add fluctuation, like for any test, if you ever see the term fluctuation, it could be it's always going to be delirium. It's like a code word in those tests, but you have a suspicion that something else is going on. It's not just an exacerbation. You send them to any of these area hospitals. Good luck trying to get the workup. Okay, they're going to blame everything on that's a St. Eve's patient, that's a psychiatric
Mhm.
patient. I think that you are the experts in diagnosing delirium in chronic psychiatric patients, and if you ask a neurologist, most of them aren't. You have to do it. Okay, uh, and so that's very important. And then you have to call the ER and kind of threaten them, that, we had a case, I don't know if you think, that case, where a guy, had long-term schizophrenia, he had HIV, but he was one of the early ones from the 80s who was asymptomatic. They didn't know he had HIV through the antibody. It was because they tested him. Uh, and now it's 20 years later, and now he's no longer, whatever his reason was not getting it for some kind of receptor issue. Now he had HIV, and and for instance, he had like a CD4 count of 4, not 4%. Had a SED rate of 100. Sent him to two different hospitals. They didn't do the workup, and they called it. So the psychiatrist and medical doctor at St. E's had to call the hospital and tell them you need to do a CT if there's no contraindication on a lumbar puncture, and the patient had cryptococcal meningoencephalitis. So but they knew, the psychiatrists knew. So these patients that okay, you're going to be better at that. If you have a good person to work with, fine. And then last, I probably shouldn't go into this. We asked, I don't know if you were around when that we asked an expert on delirium. It used to be a thing called the Delirium Society, and every time there's something like that, you know where it's from. It's in Boston, right? And the president, we asked him to come to St. E's to give a lecture on the topic of delirium in the chronic psychiatric patient. And he did. And he gave a very good lecture, one of the best, but not on what we asked him to give. He just gave
Mm,
it on delirium. And I realized at the time, because he doesn't know it, we're the experts on that. And so always, the better you know your patient, though mental status changes, you have a suspicion, okay, you're probably right. And if somebody tells you you're not right, you're still probably right.
mhm,
You
mm.
have to advocate, right? Your patient.
Dr. Cox?
Thank you so much. I really have to just reiterate what has already been said in terms of what a phenomenal presentation, as well as a fantastic discussion. And I would just like to add a couple of quick points. First and foremost, I think that it's important for us to see this as a psychiatric case. Even though the need for us to rely on our colleagues in neurology to help clarify that, it still is a psychiatric case. Remember that the reality is St. Elizabeth, I think, is around since the 1850s, and initially. If it's like the other state facilities throughout the United States and Europe at that time, the most prominent diagnosis within those facilities was GPI, general paralysis of the insane.
Exactly. Yes, that's true.
Mhm,
Yeah.
that's right.
So neuropsychiatric
Yep.
condition. And so these patients, because of their psychiatric presentations, their psychiatric symptoms, are going to be seen by us. And we have to take the initiative to be the doctors that we are. And this is also part of what I think in today's society goes into, perhaps not with cases of this extreme presentation of symptomatology, but why it's so important for psychiatrists to be the mental health practitioners who are leading the way in diagnosis and treatment. Okay.
Exactly.
The other thing that I would say is I'm very grateful that that this is taped and will be able to be shared. I believe wholeheartedly that every resident in WPS's jurisdiction should hear your wonderful case presentation, as well as the discussion that's taken place, as well as other psychiatric members of WPS, because of the fact that this is something that I think really does define our profession, and how we have to be thinking of ourselves both as advocates for our patients, as well as ultimately those responsible for helping our patients with problems in their mental life.
Excellent.
Yep.
That's great. I know that there's a question from Dr. Dunlap. So my question too, what happened to the patient?
So it was, I contacted the mother and father were divorced, but they got along very well. And I got them, and they both came to the hospital at the same time, and we met with him, which was kind of nice. I spoke to the family doctor for the mother because it was clear that the maternal grandmother didn't have MS, that was part of the adrenal leukodystrophy as late onset, and gave her all the information to let her know that if the mother gets symptoms that are mild, don't start doing MR, stuff for an MS workup. And so they had a pretty good meeting, and unfortunately, I think within a week after that, he died. And
Oh,
and we never got him into we tried to get him into a protocol, but we did. And Kenny Krieger, Hugo Moser, who did all the work on this, his wife still runs it. You got to be less than 18 or lower to even be seen by them. So we never able to get him. We looked and there wasn't anything. And so, it was unfortunate. At least they got to meet. Uh, and and hopefully, you know, I think the family doctor and relatives now will have some idea what's going on, and not start diagnosing late onset MS and with unnecessary treatments and so forth. I also want to add that yes, in this day and age, in particular, with all these autoimmune mediated inflammatory disorders, they often present. They may present solely as psychiatric, or with psychiatric is the most prominent problem. And this is true over the years. One of my mentors, Morris Bender, he was the first one in the English language to define transient global amnesia, which an average neurologist sees twice, 3 times a year. So the question is, why didn't Charcot and all these brilliant neurologists do it? Intellectual blinders didn't fit in with the thinking at the time. Where they all ended up on psychiatry. People myxedema madness until they realized, that it could be hypothyroid. They're on psychiatry. So the cases that I've saw of non-convulsive seizures where people are walking around and they look like they're on drugs, but you can't find any drugs, okay, who are in non-convulsive status, where do you think we pick them up? Psychiatry, right? So yes, it's like you're not psychologists. You may know a lot. It's like you're psychiatrists, and your medical stuff is important. And and so I support all of that. Yeah.
Thank you so
Yeah.
much. It's been such an outstanding presentation. I think I don't stand alone. Everyone is immensely impressed with it, and the collaboration between the two specialties is just phenomenal, phenomenal. And
That was
it's a
nice.
pleasure, Dr. Pooh and Dr. Stiller.
I want to say one last thing, okay, and then you
Yes.
cut me off. Dr. Siddiqui
Oh,
and
God.
Dr. Pooh are stars, I work with both of them, so I just wanted to throw a compliment in. Okay, yeah.
Oh, you're gonna make me cry, Dr. Stiller.
Yeah.
So, Dr. Dorfer, I'll let you take the baton.
Thank you all for a wonderful presentation and discussion. This is terrific. We usually have not had this kind of case presentation before, but this was a perfect opportunity, a perfect case. I'm sorry it wasn't a happier ending, but
Right.
I think we all learned from this, and many of us have had that experience of having the patient in the emergency room, when labeled as a psych patient, and therefore people stop
Right.
looking at their physical symptoms.
Exactly.
So I think that's an important lesson there. But I want to thank our presenters, our attendees, and we'll look forward to seeing you next month, second Wednesday. And happy Halloween.